This meeting is being recorded. Being recorded. Being recorded. Being recorded. Being recorded.
Ma'am, is my screen visible, ma'am? Niveta, ஒரு நிமிஷம்மா. Niveta, just hold. Yes, ma'am. Yes, ma'am.
Increase பண்ண வாங்க மேம். எக்கோ மட்டும் குறைச்சிரு.
Niveta, you don't have two screens there, no? ஒரு screen தானே? Yes, ma'am. Single screen, ma'am. நீங்க okay, ma. You share your screen and start talking. So good afternoon, Manana. உங்க சைடுல இருந்து எக்கோ வருதுமா, நிவேதா? டாக்டர் நிவேதா. Yes, ma'am.
Not only echo, it is all getting repeatedly coming.
Repeated. Madam, நீங்க பேசுறது தெளிவா கேக்குது.
உங்களோடது எல்லாம் ரிப்பீட் ஆகுது. எக்கோ.
Yes, ma'am. Here also it's echoing, ma'am.
So I think அவங்களோட கனெக்ஷன்ல ஏதோ ப்ராப்ளம் இருக்கு வளர். அவங்களோட கனெக்ஷன்ல ஏதோ ப்ராப்ளம்.
Just 2 minutes, ma'am. We'll sort it out.
Yeah.
Ma'am, if multiple links are open, it can be like this.
Niveta, Dr. Niveta, பேசுங்க. Please start.
Yes, ma'am.
Now you can start. Now it's okay.
No, Valar. It's getting repeated.
Sorry, Niveta, just can you sort that out?
Any other device?
Ma'am, நீங்க பேசினா எக்கோ ஆக மாட்டேங்குது. only இப்ப அவங்க இது பண்ண அந்த
அதாம்மா அவங்க
பக்கத்துல எக்கோ.
வேற ஏதாவது எலக்ட்ரானிக் டிவைஸ் இருக்கான்னு பார்த்து சொல்லு. வேற ஏதாவது எலக்ட்ரானிக் டிவைஸ்.
Niveta, நீங்க screen share start. Come back again. Take some time for 5 minutes. We can ask the next presenter. Start, ma. You can share your screen.
Yes, ma'am.
Please.
So good afternoon, one and all. So today I have a case of 18 years old male who presented with acute abdominal pain, suggestive of small bowel obstruction. CT abdomen also showed small bowel obstruction with the possibility of interception. So emergency laparotomy was performed and resection of terminal ileum was done. So this was the specimen which we received, which was around 32 centimeters. Small intestine, ileum, 32 centimeters in length. We were able to see a suspicious gangrenous area, which was around 5 cross 4 centimeter, 1 centimeter away from one receptor end and 28 centimeter from other receptor end. So on HNE, the rest of the mucosa was edematous. Otherwise, no appreciable lesions in the rest of the areas. So on HME, on scanner, we were able to appreciate a well-defined submucosal lesion. And on low power also, we were able to delineate a submucosal lesion with some focal areas of surface mucosal erosion. So on high power, the cells were appearing monomorphic with vesicular nucleus, and some of them with prominent nucleoli and moderate cytoplasm. All of them were diffuse sheets and monotonous in pattern. So this was the interim report which was suggested, which was a submucosal lesion arranged as diffuse sheets with intermediate to large size cells, moderate cytoplasm, and vesicular nucleus with prominent nucleoli. So further IHC was proceeded for this patient. So initially, since the patient was suspected as intussusception and we received a neoplasm, and the color was also gray black, we suspected probably could be melanoma or some neuroendocrine origin. So the panel of markers were run, CK, HMB45, Synapto, Promo, CD56, all these panels were run, which were negative. And in the second panel, this CD45 was thought of, which showed a diffuse positivity in 70 to 80% of the submucosal lesional cells. So further, CD3 and CD20 also showed positivity in the CD3, which was around 70 to 80%, and CD20 was negative. So CD4 and CD8 were also run in the next course, in which the CD4 was completely negative in the lesional cells and CD8 was positive. So also in the initial set, we also added CD56, which showed a positivity in the lesional cells, submucosal lesional cells, and Ka67 was also high, around 60%. So these were the panel of markers which are run, and the positivity were in CD45, CD3, CD8, CD56, and Ka was 50 to 60%. So cytokeratin was negative, synaptophysin, chromogranin was negative, S100 was negative, HMB45 negative, and CD20 was negative. So with this IHC panel of markers, we came to a conclusion that it was a T cell, NK T cell intestinal lymphoma, and under WHO hematolymphoid edition, we were able to see the intestinal T cell and NK cell lymphoid proliferation showed few NK and T cell mediated lesions here. So intestinal T cell and NK lymphoid proliferations were taken into consideration. Since CD56 were also positive in our case. The one more thing which was favoring our case was the monomorphicity here in this case. So CD56 positivity, according to WHO, were 3 lesions which were under our differential diagnosis: intestinal NK T cell lymphoma, indolent NK cell lymphoma, and because of the monomorphicity, we had a thought of monomorphic epitheliotropic intestinal T cell lymphoma. So again, we looked back into the tumor sections on H&E. We were able to appreciate few of the mucosal, in the mucosa, we were able to appreciate such monomorphic cells in few of the foci. On high power, between the glands, mucosal glands, we were able to see the monomorphic population of cells here also. This was seen only in one of the sections out of 7 to 8 sections. So with this IHC panel of markers on and the histomorphology, we were able to come to a diagnosis of monomorphic epitheliotropic intestinal T cell lymphoma. So a short introduction about this MEHTA, which is a rare and aggressive tumor, and it accounts for 5% of the GA lymphoma and less than 1% of the non-Hodgkin's lymphoma. It accounts for 1.5% of peripheral T cell and NK cell lymphoma. And the one more thing is it is not associated with celiac disease, unlike enteropathy associated T cell lymphoma. And it commonly involves small intestine and presents with intestinal obstruction. So as is our case, we have presentation as an intestinal obstruction, and the lesion also occurred in the ileum. So here the primary cell of origin is the intraepithelial cytotoxic T cells, and the molecular alterations will be mutations in SETD2 and JAK-STAT pathway. So monomorphic medium-sized lymphoid cells with epitheliotropism is the main histomorphological finding in our case. So the essential criteria according to WHO will be that there should be dense infiltration by relatively monotonous medium-sized cells and typically lacking areas of necrosis and inflammatory background. Epitheliotropism is common and no histological evidence of celiac disease in the uninvolved mucosa. And coming to the IHC markers, we had CD56 positivity and the CD3 positivity, CD4 negative, and CD8 positivity, which is classical in uh, monomorphic epitheliotropic intestinal T-cell lymphoma. And for further confirmation, we need to go ahead with the molecular SET-T2 inactivation and JAK-STAT confirmation. However, SET-D2 inactivation is more specific for monomorphic epitheliotropic T-cell lymphoma. So these are my differential diagnosis. So the primary differential diagnosis will be enteropathy-associated T-cell lymphoma, which is also aggressive as MEHTA, and the presentation will be same as small intestine. But the one thing is here, the enteropathy-associated T-cell lymphoma has an association with celiac disease, whereas MEHTA does not have any association with celiac disease. Previously, in the 2022 classification, this MEHTA was also under enteropathy-associated T-cell lymphoma type 2. Now, in the new edition, this has come into a separate malignancy. They have given it as a separate malignancy in the new version. So other differential diagnoses include indolent NK T-cell lymphoproliferative disorder and indolent T-cell lymphoma and extranodal NK T-cell lymphoma. So here, in our case, the monomorphicity is the primary thing, and the epitheliotropism and specificity is CD4 will be negative and CD8 will be positive. Whereas in enteropathy-associated T-cell lymphoma, they say most of the time CD4 will be negative and CD8 will be negative. And CD56 will also be negative in enteropathy-associated T-cell lymphoma. Whereas in indolent NK cell lymphoma, CD56 will be positive, cytoplasmic CD3 will be positive, whereas surface CD3 will be negative. And in extranodal NK T cell lymphoma, we need to look at other sites also to call it as an extranodal NK T cell lymphoma. And as I mentioned, SED-D2 inactivation is more specific for monomorphic epitheliotropic intestinal lymphoma. However, JAK-STAT mutations can occur in indolent T cell lymphoma, enteropathy-associated T cell lymphoma, and monomorphic epitheliotropic T cell lymphoma, also in extranodal intestinal lymphoma. So it is highly important with and a comprehensive immunohistochemical workup is necessary, along with histomorphological correlation for the diagnosis of MEHTA, as it is an aggressive disorder, and the survival is approximately 7 months, and 1 year survival rate is 36 to 57%. So early recognition is essential due to its poor prognosis and need for prompt therapy. So these are my references. Thank you.
Nivedita,
Yes, ma'am.
that was a good presentation,
Yes,
but I want to clarify certain points.
Yes,
See, as
ma'am.
long as the mucosal or intestinal lymphoma, any lymphoma for that matter, if it is
Yes.
interstitial, the first diagnosis of any of the monomorphic population of cells will be a lymphoma. You see,
Yes,
when
ma'am.
you see the slides which you have projected, most of the
Yes, ma'am.
glands appear quite intact, right? And
Yes, ma'am.
it looked gangrenous, but I didn't find much of a gangrenous change in the mucosa. It was all erosion was there, I agree, and some of the
Yes, ma'am.
disrupted mucosa was there, but most of the lesion was only submucosal and mainly in the interstitium. So with the monomorphic cell population, not much of involvement of the glandular component, we always think of a lymphoma. So
Yes,
did
ma'am.
you not make a diagnosis of a lymphoma in the initial stages?
Ma'am, they also sent us intussusception, ma'am. So we thought the tumor might be the
No,
intussusception.
intersusception could be because of the obstructive lesion. But, when you see the histomorphology, your
Yes,
first
ma'am.
diagnosis should be only a lymphoproliferative lesion. And you should also look for the lymphoepithelial picture. That is when the lymphocytes are intruding into the epithelium. See, malt
Yes, ma'am.
lymphoma, you have heard of malt lymphoma, right?
Yes,
Mucosa
ma'am.
associated, yeah. So that was the actual teaching earlier. But of course, you have a wide range of classification now. And now, the importance of this I want to know is whether any monoclonal antibody is available because you are specifically saying CD56 is positive in this kind of a lymphoma. And
Yes,
the
ma'am.
patient is also very young. He is only 18 years, right?
Yes, ma'am. 18
So,
years old.
yeah, so I just want to know whether any monoclonal kind of a therapy is available for such cases. At least you can give him some quality of life, right? And was there
Yes,
any
ma'am.
lymph node metastasis or anywhere else? Because was it a primary type of a lymphomatous lesion in the intestine, or whether it was only a systematic involvement of a generalized lymphadenopathy or lymphoma? These are the
Ma'am, we
things which
didn't
I
have
want.
any systemic involvement, ma'am. They just thought of interceptum. The surgery was done and the patient was discharged. So it was intimated as a critical alert, ma'am. Then only I think the further workup they have looked after, ma'am.
How is he now? Is he doing well? No idea.
Now they have been screening for celiac disease and the peripheral blood CBC are all fine, ma'am. No nodes, ma'am.
56 வந்து பெரிஃபரல் T cell and NK cell தானே போடுவாங்க, அதான் போட்டிருக்காங்க.
Okay, ma. Thank you.
Thank you, ma'am.
Yeah, one more thing, EBV you have not done, no?
Right. They have done, I think they have done. EBV was negative, they said. EBV was negative, they said.
Uh-huh. But CD56 for NK T cell, it is authority, isn't it?
Yeah.
Yeah. She has got the point. But only thing, why she went in for melanoma, other things only.
Yeah, that is
also
true. Yeah.
maybe
The gross appearance and also most of the cells that are showing eosinophilic like MEHTA, ma'am. So initially first thought we thought of neuroendocrine or melanoma, ma'am.
it's very uncommon now.
Yeah. Neuroendocrine tumor morphology will be entirely different, ma.
Yes.
This kind of a monomorphic cell population with the prominent nucleoli, we always think of lymphoma.
But this panel is they have given S100 and other things, not.
All that is negative.
Anyway, good presentation,
Yeah.
Nivedita.
Thank you. Thank you.
Good.
Thank you for that presentation, Dr. Nivedita. And can we go on to the next presenter? If Impana is ready, she can share the screen. Dr. Impana?
Yes, ma'am. I'll. My screen is visible, ma'am.
Yes, Impana.
Yeah, Dr. Impana, yes, you can proceed.
A very good afternoon, everyone. So, I'm Dr. Impana from MEHTA Hospital. So, today I'll be presenting a case of a 22-year-old male who presented to our hospital in November 25, presentation with complaints of exertional dyspnea and cough with evening raise of temperature and loss of weight. On examination, there were some enlarged bilateral cervical lymph nodes and mild hepatosplenomegaly. So we received blood for peripheral smear, which showed around moderate anemia with a HB of around 7 grams and some dimorphic picture with macrocytes, normocytic hypochromic cells, and as you can see, some polychromatophils, occasional spirocytes, rouleau formation, and also nucleated RBCs. In WBC count was normal, differential was normal, but neutrophils showed some toxic changes. Platelets appeared to be increased with some large platelets. So this was the complete hemogram. The WBC count was corrected for NRBC of 20%. So around 20 per 100 WBC we got on the smear study. So keeping in mind all these features, we gave a report of favoring hemolysis with neutrophilic leukocytosis and reactive thrombocytosis. Complementing this, the lactate dehydrogenase was also elevated with 1227. Serum ferritin was raised. Liver function test also showed a raise in total bilirubin with marked increase in indirect bilirubin. Reticulocyte count was 34%, but Coombs test was negative. So then we did an extended immunohematology workup where polyspecific and also monospecific Coombs test was done, and that was also found to be negative. So keeping in mind the non-immune causes of hemolytic anemia, we also worked up for G6PD deficiency, but that was negative. Ultrasound abdomen also showed mild hepatosplenomegaly. So what is the cause for this DAT negative immunohemolysis? So how do we work up? So we need to check the peripheral smear to look for schistocytes for extrinsic causes of hemolysis like microangiopathic hemolytic anemia, or bite cells or Heinz bodies for G6PD, or spirocytes for any hereditary spirocytosis, sickle cells for sickle cell disease. So all these were ruled out in our case also. So simultaneously, lymph node biopsy was done. The lymph nodes were enlarged and showed complete loss of architecture. As we can see in low power, there were some irregular diffuse bluish and pinkish areas. Some nodular aggregates of cells, which I'll focus on high power. So in high power also, we can see diffuse bands, eosinophilic bands running throughout. And in between, we can see some lymphoid cells, some plasma cells, and many histiocytic and large Hodgkin-like cells with irregular nuclear membrane, prominent nucleoli, and some with some binucleated cells also we saw. So keeping in mind all this, we thought of a lymphoproliferative disorder like lymphoma favoring a Hodgkin lymphoma, and immunohistochemistry was done outside, which showed all the markers like LCA, CD20, CD79A, OCT2, CD3, 43, and even EBV LMP was negative. One was negative. CD30 and CD15 was strongly positive. PAX5 was weakly positive in large cells with a Ki67 of 45 to 60%. So this was a classical Hodgkin lymphoma. So after excluding other variants like mixed cellularity due to absence of any eosinophils, neutrophils, or a nodular lymphocyte or a lymphocyte-rich type because of the absence of too much of lymphoid cells in the background and prominence of a diffuse reticular fibers. So we concluded that this could be a lymphocyte depleted type of a classical Hodgkin lymphoma. Also, since CD30 was positive, we wanted to rule out a ALK negative anaplastic lymphoma, which was complemented by the BOB1 positivity. Even reticulin was done in this case, which highlighted the increased reticular fibers in the background. So this was a case of a DAT negative hemolytic anemia associated with classical Hodgkin lymphoma. So as we all know, hemolytic anemia is associated with lymphoma, but the prevalence is very low, like 0.2 to 2.7% in Hodgkin lymphoma. The immune-mediated hemolytic anemia is most commonly seen associated, and in that it is associated mostly with nodular sclerosing type and in mixed cellularity type. So what are the cause for this hemolysis? It is mainly due to immune dysregulation caused by RSLs, or even due to abnormal cytokine production, loss of T cell regulatory control, polyclonal B cell activation. So this makes this autoimmune hemolytic anemia a paraneoplastic autoimmune phenomenon which is seen in Hodgkin lymphoma. So the estimated incidence of that negative AIHA, as in our case, is extremely rare and is less than 0.5%. So why does this DAT negativity happens? So firstly, it could be due to low titer or low affinity antibodies, which are too low to be detected on a routine Coombs test. Or else it can be due to other non-IgG antibodies like IgA-mediated AIHA. Our routine Coombs test detects mainly IgG and C3. So this could be missed. Or when only complement-only hemolysis is used, we should do a monospecific Coombs test and rule out this also. So this patient, we ruled out all the other causes of non-immune hemolytic anemia, and also we ruled out cold type of autoimmune hemolytic anemia. So the surgeon, hematologist started him on steroids. So the steroids will respond only if the cause is due to antibodies. So the patient was treated with steroids and simultaneous chemotherapy. So as we can see, he came back in December 9th, where HP had dropped due to the ongoing chemotherapy also. But he recently came back in January and also in Feb, where his HP came back to normal, 12.6, and there was no nucleated RBC and there was no features of any hemolysis. So to conclude, that negative autoimmune hemolytic anemia in Hodgkin lymphoma is extremely rare and occurs due to immune dysregulation caused by low titer or non-IgG antibodies, which are not detected by routine Coombs test. Diagnosis requires sensitive testing and exclusion of other causes of hemolysis. Treatment of the underlying lymphoma usually will improve the hemolysis. Thank you.
That was a very good workup, Dr. Impana. I just would like to summarize and sort of highlight some of the unique features of this particular case. First of all, he is very, very young. He is only 22 years and he did not present with symptoms pertaining to lymphoma, like a generalized lymphadenopathy or a hepatosplenomegaly, things like that. But his presentation was one of a immune hemolytic anemia. When you refer the literature, sometimes the autoimmune or the so-called AIHIA, that is autoimmune hemolytic anemia, is the first presentation of a lymphoma. And all of you, I'm sure, would have read that non-Hodgkin's lymphoma like CLL is often associated with immunohemolytic anemias, which I'm sure all of you know. But the occurrence of Hodgkin's lymphoma, and that too of the lymphocytic depleted type, as it has been reported here, is extremely rare. And she has already highlighted all the reasons for the DAT negative. And most of the centers, we do only the polyclonal type of a direct antiglobulin test. But, unless sometimes it, you grossly, like as you have seen in these cases, as supported by LDH and other ferritin, which are all indicative and even indirect bilirubin high, all this is indicative of an underlying hemolytic process. The direct Coombs test is negative. As she has already reiterated the reasons for why DAT is negative in such cases, because of a paucicellular IgG antibodies or non-IgG type of an antibody, all that. So that becomes, it should be an eye-opener for any person who is feeling that it is definitely a hemolytic anemia, but DAT is negative, then please try to do monospecific DAT test, because that is very, very important. That is the second point. Second thing is always look for any, so especially if the patient is young, look for any other lymph node enlargement, because either it can be a non-Hodgkin's lymphoma association or it can be a Hodgkin's lymphoma, as in this case. And secondly, they do, when you rule out all the other causes of hemolysis and when you rule out as we have done in this case, they respond very well to therapy. That is a very reassuring point as far as the patient is concerned, as far as the clinician is concerned. So I congratulate IMPANA for the complete workup on this case, and extremely rare, 0.5% in the total incidence. So I think it definitely needs to be made aware for everybody. It is an eye-opener. Thank you for your patient listening.
Thank you, ma'am.
Yeah.
How is the patient doing now, ma'am?
Is it any HIV test?
Yeah, that also we
No.
thought, ma'am, because it was a lymphocyte depleted type, but HIV, even syphilis, everything we ruled out, ma'am. It was negative.
Okay. No,
We ruled not only that, Eril, lymphocytic depletion type is usually, we have read earlier that it is either it can be a diffuse fibrosis or it can be a reticular. But here there were, even in the slide, you would have seen that there was quite a number of, quite an appreciable population of lymphocytes. Now, that is because of what she has mentioned as a, the shift in the T cell regulation. See, the T cell regulatory, all of the PGs or whoever is listening will know that the T cell population is the one which, recognizes the antigen and can pass on the message to the B cell to produce antibodies. But here, there is a shift in the T cell regulation and it becomes dysregulatory mechanism. Because of that, the proliferation which is of the B cell, which is being blocked, is completely not there. And therefore, B cell proliferation is. That is the reason why we have a little more lymphocyte than what we see in a classical type of a lymphocytic depleted type of Hodgkin's. In lymphocytic depletion, if you see the morphology, you will find more of fibrosis, more of histiocytes. But the important point in a lymphocytic depletion is paucity of the lymphocytes. But here it is not, I won't call it a paucity of lymphocytes. But other things, like other fibrosis was there, reticulin was there, and also a lot of Reed-Sternberg giant cells were there. All this go in favor. But only the thing is the presence of lymphocytes here, not the depleted type. But the reason for that is the immune modulation and the dysregulation of the T cells. That was an excellent point, I thought. And so everybody should be aware of such things, the immune mechanism is always a very, very complex mechanism which can do either, what shall I say, havoc, as far as the patient is concerned. So I thought we will definitely present this case because everybody should be aware of such kind of a combination.
And one more thing, clinically, the B type of fever, dyspnea, cough, all that goes in favor of lymphoproliferative disorder. And then clinically also, this case very well fit in. And, and they have a defect in the cellular immunity is more commonly seen, which because this patient respond very well, if you control the infection and other things. Very well, nicely brought out.
Thank you.
Thank you.
Thank you, ma'am.
Thank you, Dr. Impana, and thank you, Sita Madam.
Thank
Can
you.
we go on to the next presentation, Dr. MYTHILI from STANLEY?
Good afternoon to all. Thank you for giving this opportunity to me. My case details is 61-year male, known case of chronic smoker and alcoholic. Patient doesn't have any other comorbidities. Patient came to neurology OP with a complaint of burning sensation from the neck to abdomen. Patient have the muscle twitching in the upper limb, lower limb and abdomen. Patient have the symptoms of burning micturition, and during evaluation, patient also having the increased sweating and warmth during night. Patient have the sleep disturbance also. On a general examination, patient have positive findings of tachycardia and lower limb hypotonia and myokymia. Myokymia means involuntary random undulating rippled movement, and the patient also have the fasciculation. This is the small video clip of that patient. This movement is not associated with the respiratory movement. Rippled movement arising from the abdomen, it moves towards the lower limbs. So during investigation, patient have the Caspar-2 protein is positive in this case, and MRI brain shows no detectable abnormality. Electromyogram, patient have the triplet and doublet of sharp wave during resting position. Patient have this. This is the electromyography picture. So patient diagnosed as a peripheral nerve hyperexcitability syndrome. It have the two syndrome is associated with this. One is Morvan syndrome, another one is Isaac syndrome. Both have the similar pathogenesis. It occurs due to the autoantibody against the voltage gated potassium channel complex. It is mostly due to the Caspar-2 or leucine-rich glioma inhibitor protein 1. In our case, this Caspar-2 is positive in our case, and the patient also have the sleep disturbance. Isaac syndrome, the patient does not have any sleep disturbance. In Morvan syndrome, patient will have the sleep disturbance. It is a Morvan syndrome is a very rare autoimmune peripheral nerve excitability syndrome. It have the clinical triad of neuroatonomia. Patient in our patient have the myokymia, autonomic dysfunction. So in our case, patient had the tachycardia and increased sweating. Our patient also have the sleep disturbance. It occurred due to the many causes. One is toxin and drug. In our patient, we have the history of alcoholism. So treated with the methylprednisolone along with IV immunoglobulins, but a patient responded partially only. So we evaluated for the paraneoplastic syndrome. We did the CT thorax and CT abdomen. In CT thorax, patient have the small ground glass opacity in the apical region of right lung, and in CT abdomen shows the 3.5 cross 4 cross 3.5 centimeter cystic lesion in the lower pole of the left kidney, and enhancing peripheral soft tissue component with the peripheral calcification near the renal hilum also noted in our case. So they suspected as a renal cell carcinoma. Patient diagnosed a renal cell tumor with a Marfan syndrome. Then patient referred to surgical oncology for further management. They did the left radical nephrectomy. After that, patient responded well. Patient was symptom free. We received the left radical nephrectomy specimen measuring the 13 cross 8 cross 3 centimeter, and hilar region shows the cyst measuring 4 centimeter in diameter with a mural nodule. It is measuring the 3.5 cross 1.5 cross 1 centimeter. Histopathology shows the tumors are arranged in the trabecular cords and acinar and focal papillary pattern. It is the 10x view of the tumor cells arranged in trabecular and nest pattern. This is the high power view showing the nuclear feature of salt and pepper chromatin and moderate cytoplasm. So we thought of two differential diagnoses. One is neuroendocrine tumor, another one is metanephric adenoma. In metanephric adenoma, and that have the primitive appearing tubular appearing cells. It is positive for the WT1. Neuroendocrine tumor, for neuroendocrine tumor, we did the synaptophysin. It shows the cytoplasmic diffuse positivity, focal CK7 positivity, and K67 index is 3%. We did the WT1 for the metanephric adenoma and Paxide to rule out the renal cell carcinoma. Both of them is negative. Positive markers are synaptophysin. K67 index is 3%. So we arrived the diagnosis of well-differentiated neuroendocrine tumor grade 2. And neuroendocrine tumor is incidence is relative rare. 2% of it occur, 2% of all malignancy with annual increasing annual incidence 2.5 to 5% per 1 lakh population. Primary site is most commonly rectum, followed by colon and lung, pancreas and stomach. In kidney is extremely rare. Neuroendocrine tumor with neurological manifestation is also rare. It is usually associated with the primary or metastasis to the brain or spinal cord is associated. But in our case, renal neuroendocrine tumor is associated with the neurological symptoms. It occurs due to the paraneoplastic syndrome because tumor will produce the antibody that cross-react with the voltage potassium channel complex. So it will produce the it will attack the neuronal tissue. So patient will have the neurological symptoms. This is the case report and case study. It is very rare case, neuroendocrine tumor in the renal origin. Only few cases are reported, but Marfan syndrome usually associated with the thymoma and small cell carcinoma of lung and solid pseudopapillary pancreatic tumor. But in our case, it is associated with the renal neuroendocrine tumor. This case highlights the rare presentation of neuroendocrine paraneoplastic Marfan syndrome associated with the well-differentiated renal neuroendocrine tumor, while Marfan syndrome is mostly associated with the thymoma and small cell carcinoma of lung. This case expands the spectrum of underlying malignancy. Thank you.
Yeah, very nice case presentation. It's an addition to what we had reported as a paraneoplastic phenomenon.
Yes,
This
ma'am.
is another example of paraneoplastic syndrome, which all of us have known. Yeah, very nice case.
So initially the patient had neurological manifestations only, ma'am.
There is some disturbing noise while echoing there. I think there's some other.
Echo ipo illa, madam.
I know, I saw.
So initially the patient had neurological manifestations and he was done a CT and incidentally they picked up a lesion in the kidney and nephrectomy was done and it turned out to be an even rarer tumor, a neuroendocrine tumor in the kidney, ma'am. So, and all his symptoms disappeared after nephrectomy. That was, we were told, and he's fine now.
Very good. And the only thing is, we are not sure what the lung lesion is, whether that is also a neuroendocrine tumor. You see here, the CT had reported a lung
Ma'am, PET scan
lesion
taken.
also, isn't it?
Patient doesn't have any active lesion in the lung, ma'am.
No active
Oh.
lesion in the lung, ma'am. PET scan was done.
Oh. Okay.
So he was having sleeplessness and all that disappeared after nephrectomy. All his neurological symptoms disappeared after nephrectomy.
Yeah.
Well,
Now, on whose advice they did?
which is the primary now? The kidney is the primary or any other primary somewhere?
RCC is the primary.
Illa, madam, kidney lesion, it is a primary lesion, ma'am. There was
That's
no
what,
other
yeah.
Have you ruled out the colonoscopy and other things? Lungs?
Ma'am, PET scan பண்ணிருக்காங்க and
Panniyachi.
it was the
Okay.
primary neuroendocrine tumor of the kidney and இது ஒரு rarest of the rare association.
ஆமா
Yeah, I know.
நினைக்கவே இல்லை.
இல்ல எப்படி வந்து திடீர்னு see when you have symptoms of you have worked up very well the neurological manifestations, but suddenly why you switched on to abdominal CT?
Ma'am, அந்த patient வந்து neurological symptoms ஓட present பண்ணிட்டு இந்த it could be a paraneoplastic syndrome, so just send him for a CT. They never expected a lesion in the kidney. It was all it was
What
all
was the blood pressure of the patient?
Normal. It was all normal. Yeah. So, but you
I was thinking pheochromo மாதிரி போதேன்னு பார்த்தேன். Perspiration, sweating.
Neurology, they have done this, ma'am. Neurology department of Stanley, they have done, and they have after they have proceeded for CT.
Why did they think of a paraneoplastic syndrome? Because you see all the lesions in the brain, of course it was all negative, but myograph showed all the triple and multiple twitching and all that, involuntary twitching of the muscle and all that. But why did they think of a
potassium loss naladu?
Why did they think of a paraneoplastic syndrome? That is my they never thought of anything.
They thought of a toxicity due to alcoholism, ma'am. They treated with methylprednisolone and IV immunoglobulin. They are only partial response only they have. So they thought of
they went ahead with
they took a CT thorax and abdomen, ma'am.
Okay. Anyway, that was a very good workup, I should say, because otherwise they would have missed the lesion. If they have not done the CT abdomen. Yeah.
So the neurological manifestation only pointed towards the abdominal lesion. That's it.
Yeah, that is what. Very nice.
Yes, ma'am. Thank you.
Very rare.
Yes.
Excellent.
Rare presentation.
That was a good presentation from Dr. MYTHILI.
Very good.
So, can we go on to the
Congratulator.
Yeah.
Dr. Harish, if you're ready, you can share your screen.
MMC.
You can start your presentation, Dr. Harish. Welcome. Dr. Harish, you're not audible. Do you have a device? Do you have a Bluetooth device with you? You have to mute that.
Am I audible now?
Yeah, you're audible, but உங்ககிட்ட Bluetooth device ஏதாவது பக்கத்துல இருந்துச்சுன்னா I think you have to take it off. இல்லனா echo ஆகும்.
Oh, nothing is there. Only the speaker is there actually.
Okay, then you proceed.
Yeah, thank you, ma'am. So, good afternoon, one and all. So nice to presenting a case in the city pathologist meet, and thank you, Valermidi ma'am, for giving me this opportunity. So, I'm going to talk about an interesting case which we received a few months back. So, I'm a perinatal pathologist, and we do exclusive fetal autopsies in Department of Perinatal Pathology in MEDISCAN systems. So, we received a fetus from a 31-year-old Prami Gravida, non-consanguineous marriage. The ultrasound was done at the gestation age of 21 weeks 5 days, and all growth parameters were lesser centile for the gestation age. So the suspected early intrauterine growth restriction, and there was generalized edema surrounding the fetus, moderate ascites, increased nuchal fold thickness. So features were suggestive of non-human hydrops, and fetus was terminated for this anomaly and sent for autopsy. So we received 24 weeks fetus for autopsy, and on external examination, the parameters were corresponding to 20-21 weeks gestation age. So the findings externally was suggestive of intrauterine growth restriction. The head was relatively large, and there was generalized subcutaneous edema. The face was mildly dysmorphic with downslanting palpebral fissures on both eyes, and the ears, as seen here, was low set and posteriorly rotated. The neck was short with nuchal edema, and the thorax is short, and abdomen is protuberant and distended. All four limbs were thin, and fists were clenched, and all fingers showed clinodactyly of all fingers. And the foot showed a lomodactyly and bilateral callipes equinovarus deformity. So this completed, the external examination is completed, and we opened the fetus. And on internal examination, we noticed the thorax was short, which was confirmed, and there was a hypoplastic lungs and thymus associated with the vertically shortened thoracic cavity. The diaphragm was intact, and the liver, as you see here, is congested with a granular appearance and markedly enlarged. The intestinal loops were patent. Kidney, ureter, bladder, and every other organs were normal, except for spleen here, which was also markedly enlarged. So there was hepatosplenomegaly. Heart was structurally normal, but there was a finding called apparent origin of right subclavian artery, which was arising from descending aorta. Apart from that, the heart is structurally normal. So this is an enlarged image of the hypoplastic lungs and thymus. So on a placental examination, the placenta appeared bulky, the cord was thick, and the umbilical cord showed features of hypercoiling, where there are more than 3 to 4 coils per 10 centimeter, and the coiling were arranged in a corkscrew fashion, and the villi was edematous. So after the examination, we gave sections for histology. So the multiple organs, especially thymus, showed multiple large cells with eosinophilic cytoplasm and with a peripheral hyperchromatic nuclei. So, and there was also associated lymphocyte depletion. So these findings were consistent with those of Gaucher cells. And on histology of other organs like liver, adrenals, gonads, also showed similar gaucher cells. So on colluding the external findings and internal findings with the histology, we arrived at the diagnosis of perinatal lethal Gaucher disease. So Gaucher disease, perinatal lethal disorder comes under a type 2 perinatal form of Gaucher disorder, and this is an autosomal recessive disorder with a 25% recurrent risk in every pregnancy. And this is the most common lysosomal storage disorder. So it results from deficiency of beta glucosylase with consequent accumulation of glucose cerebroside in reticular endothelial cells. So the gross findings, as we have seen, is massive hepatosplenomegaly, edematous fetus, and skin abnormalities. Microscopically, lipid-laden macrophages with tissue paper cytoplasm, which is classical of Gaucher cells. And there was widespread infiltration of liver, spleen, bone marrow, and lung, and the prognosis is very poor in this case. So that concludes my presentation. Thank you.
Very nice case, doctor. And did you do the parental genetic investigations and counseling?
Actually, we discussed with the genetic team. Actually, the parents were not willing for a genetic workup, ma'am.
Was it the first child only?
Yes, ma'am. Primary gravida, ma'am.
Yeah, I know. But
So
so you have to.
we suggested genetic counseling, and we sent them for the counseling, ma'am. So we had to follow it up with that.
Oh, because genetic workup is important to
Yes.
at least find out for the next pregnancy, right?
Yes,
Yeah.
ma'am. Yes, ma'am.
Very nice case. First
Thank
time
you.
I'm seeing after so many years a Gaucher.
Yes,
Yeah, and we always used to teach the postgraduates as
During
wrinkle the
our
tissue
PG
paper
days,
appearance. Yeah, yeah. Wrinkle the
Never
tissue
heard.
paper appearance is the commonest type of a thing which we always used to teach the postgraduate.
Remember.
Yeah, very nice.
Thank you, ma'am.
இது என்ன டைப்ல வருது இது டைப் 2ல
Type 2.
டைப் 2 acute neuropathic type is a severe form இல்ல
Somebody has asked whether the brain was autopsied.
Yes, ma'am. We examined all the organs, and the brain was structurally normal in this case. The brain showed mild hypoautolytic changes, but it was within normal limits. The cortex were corresponding to 22 to 23 gestation age, and gut section also it showed normal lateral ventricles, and posterior cranial fossa also showed normal cerebellum, vermis, fourth ventricle, and brainstem.
the parents never normal.
Yes, ma'am.
That's what they didn't want. They didn't want a genetic pattern investigations.
Not concerned on us. That is the only information that we have.
Yeah.
They
Thank you,
should
doctor.
actually, we should do the workup for the how they inherited the thing. Anyway, we have to read it again.
Yes, ma'am.
You've given us a homework. Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Thank
Thank
you.
you.
Thank you, ma'am. Thank you, Dr. Harish,
Thank you,
for
ma'am.
that beautiful case. And can we go on to the next presenter, Dr. Roselin from SRINGERI?
Poor Valer.
Yes, ma'am.
Not able to hear Harish at all. Very feeble. I don't know
அப்படியா?
what to say. ஆமா,
மேடம்
எனக்கு
எங்களுக்கு
கேட்கவே
நல்லா
இல்லை.
இருக்கு மேடம்.
It was
Maybe.
okay. It was good only. It was good only.
ஓ
There was no
தெரியல
problem.
ஃபர்ஸ்ட் கொஞ்சம்
நீ மட்டும்
தகராறாச்சு இல்ல
உன்னோட இதுல சிஸ்டம்ல வந்து நீ கம்மியா
ஆமா
வச்சிருக்கியான்னு பாரு.
அதான் பாக்குறேன். ஓகே
நல்லா.
ஓகே
ஓகே மேம்.
ஓகே
டாக்டர் ரோஸ்லின். Yeah, your screen is visible, Dr. Roselin. You can start. Dr. Roselin, you can start.
Ma'am, am I audible now?
Yeah, you're very much audible. Please continue.
Okay. Good afternoon, everyone. I'm Dr. Roselin. I'm working as a senior registrar in SRINGERI Hospital. So with me is Dr. Deepa ma'am, HOD of Department of Pathology, SRINGERI Hospital. So I'm presenting a case of a 53-year-old female patient who presented with complaints of abdominal pain. So CT abdomen was done, which showed one large mass in the lower pole of the kidney and also other two enhancing lesions. Uterus also showed a large fibroid. And CT chest has been done, which revealed there is a small pulmonary cyst in bilateral lungs. So this is an image of CT abdomen. So in the first picture, we can see there is a large mass in the lower pole of the kidney, and in the rest of the two pictures, this is one lesion on the over the cortex, and there is another lesion. This is a gross finding. Actually, these pictures were taken after we saw the microscopy. That's why a bit broken images are there. So this is the dominant lesion, which is about 4 centimeter in maximum dimension. On cut section, we also saw multiple other whitish firm areas like firm nodular lesions. There is one lesion here and there's another lesion here. The uterus showed a subserosal fibroid, which is about 25 centimeter in maximum dimension. So on microscopy, this is the microscopy of the dominant lesion, which is about 4 centimeter. So that showed oncocytic nature, like it showed well-nested tumors with intercepting fibrous septae. And there is no evidence of no necrosis, no lymphovascular invasion was there. And on high part, the cytoplasm looked eosinophilic and granular. Overall, it looked like a low-grade, it was towards low-grade morphology was there. And so we had a differential diagnosis of entities which had similar overlapping morphology of the same eosinophilic architecture. So one is oncocytoma. Then we had a differential of low-grade oncocytic tumor. Chromophobe RCC was also kept under a differential, and clear cell RCC, eosinophilic variant, and TFE3 rearranged and TFE3 altered RCC, and also papillary RCC type 2 because it can also have the same eosinophilic and granular cytoplasm features. This is the image of the multifocal lesions which was there. So this showed fascicles of spindle cells which apparently looked very bland. There were no evidence of mitosis. There is no necrosis. And also some mature adipose tissue was also found in this, and it also has some trapped tubules and it also had thick and thin wall blood vessels, as you can see in this picture. So we had a differential of renal angiomyolipoma for this, and also renal leiomyoma, mixed epithelial and stromal tumor of the kidney. And we also had malignancies into a differential, such as well-differentiated liposarcoma and renal cell carcinoma, clear cell type. This is a picture of the uterine mass. It showed fascicles of bland spindle cells with some areas with hyaline degeneration and some hydropic change. And also there were some areas which showed bizarre nuclei was also evident, which had, as you can see in this picture. This IHC was done on the main lesion, the large lesion, which was about 4 centimeter. So it was in the kidney. So it showed PAX8 positive, so which proved that this is towards the renal epithelial tumor. And CK7 was positive. CD117 is negative. CD10 is also negative. AMACR is also negative. TFE3 showed aberrant positivity, and CA9 is negative. So with this, we ruled out chromophobe RCC. We also ruled out papillary RCC and clear cell RCC. And TFE3, though it is positive, the morphology of oncocytic tumor is more towards oncocytic tumor rather than a TFE3 altered or a TFE3 rearranged tumor. So with this, we rendered the diagnosis of low-grade oncocytic tumor for the kidney lesion, dominant lesion, and the multifocal lesions in the kidney, we rendered a diagnosis of fat-poor angiomyolipoma. And for the uterine mass, we rendered a diagnosis of leiomyoma with focal bizarre nuclei. So let's have a peek into the oncocytic tumors. So this low-grade oncocytic tumor is actually a new entity which has been added in the 5th edition of WHO under other oncocytic tumors of the kidney. So this is a new category which is added below the oncocytic and chromophobe renal tumors. In the oncocytic tumors of the kidney, there are entities which are included, where low-grade oncocytic tumor, eosinophilic vacuolated tumor, and also tumors which have morphology between oncocytoma and chromophobe RCC. They are classified as oncocytic renal neoplasm of low malignant potential, not otherwise specified. And for the tumors which have a borderline features and which occur in hereditary cases such as Bird-Hogg-Dubé syndrome, they were classified as hybrid oncocytic tumors. So for this patient, we had renal angiomyolipoma, and then there is a low-grade oncocytic neoplasm. There is also uterine leiomyoma. Seeing this, it points towards the proliferation of both mesenchymal lineage and epithelial lineage, which is actually a systemic hematomatous pattern. So we suspected it could be because of mTOR pathway dysregulation, warranting testing for genetic analysis for tuberous sclerosis 1 and tuberous sclerosis 2 gene. So we did molecular testing. This was actually sponsored by the hospital because we need to find out what is actually the cause. So this test was actually sponsored by the hospital, and genetic analysis revealed there is a pathogenic variant of TSC2, which is an autosomal dominant heterozygous variant. So TSC2 is actually a gene which acts as a heterodimer. TSC1 and TSC2 is actually a heterodimer which actually blocks the mTOR pathway. So it puts a brake on the mTOR pathway, preventing uncontrolled cell growth and proliferation. So when there is mutation, loss of function mutation in the TSC genes, the mTOR pathway becomes unregulated, and which will lead to uncontrolled cell growth and proliferation, hence leading to the tumorogenesis, the pattern which we saw in this patient of multiple tumors, of renal tumors. There is uterine tumors, and also she had bilateral cyst in the bilateral lungs. So our insight about this case is that it is important to consider tuberous sclerosis complex when we see multifocal renal tumors, especially angiomyolipoma, which is actually a hallmark tumor for the tuberous sclerosis complex. And the importance and awareness of this entity, low-grade oncocytic tumor, which is actually mTOR-driven pathway. And IHC is important for distinction because low-grade oncocytic tumor is a low-grade tumor. After resection, it only needs a clinical follow-up, and the patient is not on, it's not going to recur again. So IHC is important to diagnose, to differentiate this benign entity from the other aggressive entity. And also genetic analysis is important because we need to confirm the diagnosis and also for the differential diagnosis for therapeutic guidance and targeted medicine, because this patient is positive for TSC2, which is actually mTOR driven. So we have mTOR inhibitors such as everolimus, so which will help in preventing the tumor progression and also for the shrinkage of the tumors, and also for severity prediction, because TSC2 is more severe. The patients can have more tumors, and they can have earlier onset and multiple progression compared to TSC1. And it is also important to distinguish between hereditary and sporadic mutation, because this hereditary mutation means that the patient and their siblings, their children, everybody are under risk, and it is important to do a screening and also for the counseling of the patient. Thank you.
I think today is a day of rare cases day. So many rare cases, yeah. And what I want to know, doctor, is how is the patient doing, and what is the modality of treatment with so many tumors he is harboring, she is harboring? How are they managing so many tumors?
Ma'am, so the kidney was resected, kidney resection was done, and uterus is also removed. So, only the lung cysts are there, which they haven't done anything. The patient is yet to come for a follow-up. So the genetic test report came only very recently. So I am yet to talk to the clinicians to find out what exactly will be their approach for this patient.
Yeah, because it's quite perplexing to have so many lesions in one patient.
Exactly. Yes,
So, you called the leiomyoma not atypical. I mean, those were only something like an ancient schwannoma where we see so many these kind of smut cells. You know, you just focused one photograph. There were any pleomorphism. You want to call it an atypical leiomyoma or what is
No,
it?
no,
What
ma'am.
was the
There was only one focus of bizarre nuclei. Otherwise, predominantly it was very bland.
Cellular leiomyoma.
Okay.
This was just
Okay.
one focus where we saw these bizarre. So that picture has been put, but otherwise it was predominantly like a benign leiomyoma.
Okay.
No increased mitotic activity, no necrosis.
Okay.
Yeah.
So many lesions are there. Okay, then uterine is okay, but renal cell carcinoma and so that has to be dealt with, right? Okay.
Yes, ma'am. So this is low-grade oncocytic tumor and multiple angiomyolipoma. So radical nephrectomy has already been done. Now, after this genetic testing, now as said, it could be hereditary or sporadic. So the patient is yet to come, and we are they'll probably be on follow-up, and all those things I'll have to clarify with the oncologist to find out what exactly will be their approach. So the patient is not very affordable. We could do only the ISC for the kidney main lesion, and this TSC also, because of our curiosity, academic curiosity, I was like, we have to sponsor this and find out if the patient has this
That's
genetic
good.
mutation.
Yeah, that's good, doctor. That's very good.
What about the pulmonary cyst bilateral something you said?
That we haven't biopsied or diagnosed, ma'am. Suspicion. Whether it could be a lymphangioliomyoma because it is associated with TSC. This is one suspicion. But I think patient is not symptomatic for lungs, so they haven't yet disturbed that. But they haven't done a biopsy for the lung lesions.
Okay.
Very nice case, doctor. I just
germline mutation is not done.
Ma'am?
Germline mutation not done.
Germline only done for the patient, ma'am. We have done. So that is TSC2 pathogen. That is germline mutation testing only.
Okay.
Yeah, very nice case, doctor. Very nice case. One thing, does the patient have any phenotypic features of TSC like Shagreen patch? Because we had a couple of cases where, so many things are there.
Yes.
Whether there is any...
So I haven't, I did not see the patient. Yes. But I spoke to the surgeon, and when I told him that there's a suspicion of TSC, he said, yes, I think I saw some skin patches similar to TSC. So he said, yes, I could see something in terms of...
it may be a full-blown, phenotypically also with all these tumors and a typical TSC. He might have other phenotypic stigmata of...
Phacoma is another one, no? Like phacoma of the eye is another added feature in this.
Yes.
Shagreen patches.
And Shagreen patches, and then you can have cortical tubers. You can have many other, cardiac rhabdomyomas.
Yes.
We had, and many of these renal cell are associated. The newer entities are associated with TSC, like your eosinophilic solid cystic.
So here the main thing was CD117 for us. So all the other oncocytic tumors, they would be positive. But this low-grade oncocytic tumor is one where CD117 is negative. So
you could also do cathepsin K, because cathepsin K, it may be positive in LOT. Cathepsin K.
Okay.
It's very rarely found. Not every center would have.
Not every center has it. I think I ordered for it, but it was not there. We outsource our IHCs. So I ordered for cathepsin K, but it wasn't there.
It's not available.
The available markers.
Yeah. That would be completely very nice case. Excellent. Thank you.
But does TSC1 and 2, the tumor suppressor genes in chromosome 9 and 16, they'll be commonly seen in the normal organs also, variety of normal organs.
Yes, ma'am.
Mutation in TSC1 and they lead to autosomal dominant inheritance.
Sorry, ma'am?
That mutation in TSC1 and 2, they have an inheritance of tuberous sclerosis complex with hematomatous lesion in many tissues and organs. Like that would have been there.
Yes, ma'am.
The cause for the thing.
Yes.
Okay. Very nice case. I've seen one during my PG time, if I remember whether Dr. Sita remembers tuberous sclerosis. I
remember tuberous sclerosis complex we have done, and
one case
I remember. I do
the Shagreen patch.
This is my first case This is my first case here, ma'am. This whole thing.
Angiomyolipoma, it is always associated. So I think that was a case of an angiomyolipoma, if I remember right. The patient had all these features.
Yes, our case was with the angiomyelin. That time only it was highlighted. First namakku.
Yeah, that's true.
During our PG time, Sita.
Yeah, that's what. That is in GH. Yeah. How many years back? 30 years back.
1985. Way back, but still we remember that, no?
Yeah, because they're all interesting cases, no?
Okay, ma'am.
Bye.
Thank you, ma'am. And incidentally, today is Rare Diseases Day. That's why I.
Rarest of rare.
Yes.
rare.
Inniki Rare Diseases Day. It is a day for dedicated to rare diseases. So
coincidentally, it so happened that everything
every case happened. Yeah.
We are
every
presenting
case
the
happens to be. Yeah. We
There's a
learned so much.
coincidence. Yes, ma'am.
We
So we
learned
go
so
on to the next case, Dr. Badrinath from Tirupati. Can you share your screen, Dr. Badrinath?
Yes, ma'am. Good evening, ma'am.
Yeah. Your screen is not visible.
Yes, ma'am. I'll just share it, ma'am.
You need some time, Dr. Badrinath.
Ma'am, is it visible now, ma'am?
No, it's. Or can you just sort that out? Can we go to the next presenter and come back to you?
Yeah, ma'am, sure.
Sort out pannunga. We'll go to the next presenter and come back to you. Dr. Harishkumar, the next presenter, Dr. Harishkumar. Dr. Harish is done. Dr. BANUKEERTHANA from SRMU.
Ma'am, am I audible?
Yeah, you're audible. Please share your screen. Dr. Banu?
Yes, ma'am. Just a minute, ma'am. Just a minute. Sorry.
Banu?
Ma'am, just a minute. I'm not able to share my screen.
Yeah. Just sort it out. Yeah.
How many more cases were there?
Dr. BANUKEERTHANA and Dr. Badrinath. 2 cases.
Okay.
Can we go on? If Badrinath is okay, if you have sorted out, you can present.
Yes, ma'am.
Thank you.
Ma'am, is my screen visible now, ma'am?
Yeah. Good. You can start.
Yeah.
Thank you.
Good evening, respected seniors and my colleagues.
Louder.
Thanks to
You're
Valamati
not
ma'am for
audible.
giving me this. Am I audible now, ma'am?
Dr. Badrinath, it's not very clear.
Okay, ma'am. Ma'am, is it audible now?
Koncha volume increase. Yeah.
He has to mute
Yeah,
other devices if he has.
No, all my other devices are muted now.
Then proceed, please proceed.
Yeah, ma'am. Good evening, ma'am. And this is my case. Okay, this is a 75-year-old female who presented to us center with the symptoms of bleeding per vagina for last 2 months. Patient was already worked up in another hospital, and hysteroscopic either endometrial biopsy was already done. And it was reported as endometrial carcinoma. And as per protocol, the slides and blogs were submitted at our center for in-house review. This is a low power view of the endometrial biopsy, where we could appreciate a dual population of tumor cells composed of well-differentiated adenocarcinoma, and in the background of necrosis, again a high-grade carcinoma component was there. And on high power view on a scanner view of your well-differentiated adenocarcinoma, it looks more like an endometrial adenocarcinoma, where the tumor cells are arranged in back-to-back glandular, villus, and in papillary pattern. And in high power view, the nucleus started rounding up with nuclear stratification, vesicular chromatin, and nucleoli. This is a feature of your well-differentiated endometrial carcinoma. And again, coming to this high-grade carcinoma component, where the tumor cells are arranged in the intersecting trabeculate cords and in a desmoplastic stroma with almost like myxoid change of your stroma. And coming to the high power view of the tumor cells, these areas started losing the appearance of your differentiated carcinoma. They become more like a neuroendocrine component, where the nuclear overlapping was there along with nuclear molding and mitotic figures were there. So with this histomorphological findings, we made a diagnosis like there is a well-differentiated adenocarcinoma component also, endometrial type, along with that high-grade carcinoma component was also there. So we went ahead with doing IHC marker. We did PAX8. PAX8 came strong and diffuse positive in a well-differentiated component, whereas your high-grade carcinoma component was PAX8 was like focal to almost negative. And ER came strong and diffuse positive in your well-differentiated carcinoma component, whereas they are almost negative in your high-grade carcinoma component. And P53 was wild type or heterogeneous staining pattern was there in both your well-differentiated and high-grade carcinoma component. And we did MMR IHC, where MSH6 was showed intact nuclear expression in both your well-differentiated and your high-grade carcinoma component, whereas PMS2 was lost in both your well-differentiated and your high-grade carcinoma component. The internal control was positive, whereas your tumor cells were negative. So, based on this histomorphology and IHC panel, we made a diagnosis of the dedifferentiated endometrial carcinoma. And patient's radiology was also done, and with MRI pelvis showing lesion in the endometrial canal, with involvement of more than 50% of the myometrium with suspicious extraserosal involvement. As per figure 2023, dedifferentiated endometrial carcinoma is aggressive histological subtype. So the surgeons went ahead with extensive surgery like THBSO with bilateral pelvic node dissection and omentectomy was done. And in the resection specimen, the serosa was inward, whereas the nodes and omentum were free. So we finally staged this tumor as PT3A, PN0, and figure stage was 3A2 was given. As per protocol, the patient was receiving adjuvant chemo and radiotherapy now. Into discussion, dedifferentiated endometrial carcinoma constitutes around 2 to 8% of your endometrial carcinoma. On histomorphology, is a biphasic tumor composed of a low-grade endometrial carcinoma with an undifferentiated carcinoma component. And even though stage-wise, if it matches with your grade 3 endometrial carcinoma or your serous carcinoma, it has a very bad prognosis because they're usually associated with a switch chromatin remodeling complex deficiency. And usually these tumors will show MMR deficiency, and in our patient, PMS2 was lost. So most likely patient must be having Lynch syndrome. We have to check our patient for germline testing, check our patient's relative for germline testing to look for Lynch syndrome. This is my case. Thank you.
Dr. Badri, dedifferentiated endometrial carcinoma. Can you just show the findings again, please?
Yeah, no.
My question is whether the endometrioid is going for a dedifferentiation or was it something like a collision tumor or both component coexisting?
No. It's endometrioid carcinoma going for a dedifferentiation.
Okay.
This this is a well-differentiated endometrioid carcinoma. Most likely it will be grade 1. And this is a high-grade carcinoma component. And this is a background necrosis. In endometrial biopsy, whenever background necrosis is there, we have to suspect either it's like more than 50% myometrial involvement is there, or it's associated high-grade carcinoma can be there in the resection system. But in our biopsy itself, this high-grade carcinoma component was there.
Okay.
What about the IHC in that dedifferentiated area?
Ma'am, IHC in the dedifferentiated area, PAX8 was negative.
Was
Even
positive?
if it's a grade 3 PAX8 was negative. Negative. Once
completely
it
negative, or there was some
it will
patchy
lose.
areas?
Ma'am, this is not very focal, ma'am. This one, it's very hard to say this is positive because most of your tumor is negative. Whereas this is a very differentiated endometrioid carcinoma showing PAX8 positive, complete diffuse nuclear positivity was there. Whereas this high-grade carcinoma, once it becomes dedifferentiated, PAX8 was completely lost. And in the same way, ER was like like strong and diffuse positive, whereas the dedifferentiated component was totally dead for ER. And again, your
Differentiated
P53,
areas are seen.
yeah, and P53 was showing wild-type staining pattern. And your undifferentiated and your dedifferentiated carcinoma are usually P53 wild-type. And again, your grade 3 endometrioid and your dedifferentiated undifferentiated carcinoma will show MMR deficiency. That way you can use to differentiate it from your other high-grade carcinoma like a serous carcinoma also. So we didn't do all 4 markers. We paired with the 2 markers like your MSH6 and PMS2. MSH6 was showing expression, whereas your PMS2 was lost. So based on this histomorphologically, and again we confirmed it with the IHC, we made a diagnosis of a dedifferentiated endometrial carcinoma.
What is the incidence of dedifferentiated carcinomas, Dr. Badri?
Ma'am, it was 2 to 9%, ma'am.
So,
what is the age of the patient? It's very common in young women.
Ma'am, she was elderly, ma'am. Our patient was 75-year female because PMS2 loss was also there. She was a 75-year female, ma'am.
But generally they come in a very young age, isn't it?
Yeah, ma'am.
Young women, it's more common, undifferentiated.
okay,
Anyway.
okay, Dr. Badri.
Anyway,
Thank you, ma'am.
Yeah, ma'am. Thank you, ma'am. Thanks, ma'am.
After
Thanks
a
for the
long time.
opportunity, ma'am.
Thank you, Dr. Badri. Can we go on to the next
Thanks,
presenter, Dr. Banukirthana? Yeah, your screen is visible, Dr. Banu.
Yes, ma'am.
Yeah, you can start.
Okay, ma'am. Good afternoon, everybody. I'm Dr. BANUKEERTHANA from Sri Ramachandra Medical College. So we are here to present a case of a 16 years old female who presented with abdominal mass for about 3 to 6 months in the right upper quadrant. And there was no history of fever, jaundice, or any other constitutional symptoms. Her vitals were stable, no dysmorphism, no pallor or lymphadenopathy. And on examination in the right hypochondrium, we could see a hard palpable mass for about 3 to 3 centimeters. Her lab investigation saw this. Her LFTs were all normal. Her AFP was also within the normal limit. So CT abdomen was done, and which came out as a large, solitary, multilobulated, hypervascular soft tissue density lesion in the right anterior suprahepatic space. So no local regional lymphadenopathy. With the given radiology, the radiological differential diagnosis were hepatocellular carcinoma, focal nodular hyperplasia, cyst, and gastrinoma. After that, we received a liver USG guided biopsy of the liver core mass. So this was the low power scanner view where we could see a linear course of tissue. On going to the higher power, we couldn't see much of a parent tissue. Then we saw tumor cells that were arranged in sheets, and the cells were large with abundant eosinophilic cytoplasm with increased NC ratio. Few nice prominent nucleoli were also seen. Along with the tumor sheets, there were areas of pale bodies were also noted interspersed between between the cells. Okay, with this differential, with this given core tissue and then radiological finding, the first differential diagnosis that came to our mind was either hepatocellular carcinoma or hepatic adenoma was also to be ruled out. So we went for reticulin stain, which confirmed the pattern for hepatocellular carcinoma, and then further IHCs were also done. We were thinking of hepatocellular carcinoma, so glypican was done, which turned out to be negative, and Ka67 was very, very low. So again, we started reviewing this slide and with the history and with the radiology. Given the age of the patient was only 16 years old and AFP levels were not much elevated, and morphology showed abundant eosinophilic cytoplasm, abundant eosinophilic cytoplasm nuclei, whereas glypican also negative. With the given history, we thought a differential diagnosis of a fibrolamellar variant of HCC, where then we went for IHC like CK7, which was positive in tumor cells, as well as CD68, which turned out to be very positive in this case. The case was further discussed in the tumor board with the clinician. In spite of thinking the differential diagnosis for fibrolamellar disease, we requested the clinician for an excision of the tumor, and hence we gave it as atypical hepatocellular nodular lesion. We did not want to commit over here. Hence, we received a left hepatectomy specimen where we could see a portion of liver, and the entire liver is replaced by the tumor, which is partially circumscribed, nice greenish tumor with the central areas of scarring. Central stellate scarring was also present in this tumor. So going to H&D pattern, the low power view showed sheets of tumor cells that were interspersed with collagen fibers or fibrosis-like areas. Next power, which also showed sheets of tumor cells with abundant eosinophilic cytoplasm, pleomorphic nuclei, and they are further interspersed with fibrous areas or fibrosis. This is another high power view where we could see nice bizarre cells with prominent nucleoli, and then they are further interspersed with collagen and fibrous areas. This is a slide showing the areas of necrosis. So given the differentials, we wanted to rule out focal nodular hyperplasia, where it would have had some ductular reaction, which was not present in our case, and hepatocytes would have been bland in FNH. In our case, it was highly pleomorphic. The other differential diagnosis that we wanted to rule out was HCC with cirrus type, where there will not be any central scar, there will be increased AFB and no oncocytic change. So empty stain was done just to demonstrate the collagen that's interspersing the tumor cells. So by IHC, the CK7 was focal patchy, showed focal patchy positivity, and Ka67 on the repeat slide, it was about 20%. CD68 was positive, which was not repeated in the main tissue, and then glypican was negative. So with the given history, and the tumor fall into the classification of PT1B, the solitary tumor greater than 2 centimeters without vascular invasion. So we gave an impression of PT1B N0, moderately differentiated hepatocellular carcinoma, fibrolamellar type, and margins were free of invasive carcinoma. Since it is one of the rare cases, we wanted to confirm with molecular testing also, and hence we are awaiting the molecular fusion testings. So on going further for the fibrolamellar HCC, it is one of the distinct subtype of HCC, which is a very, very rare condition, less than 1% of primary liver cancers. And it especially occurs in younger age group, the adolescent and the young adults are the main. So whenever we see a tumor in the liver in the young patients, fibrolamellar HCC has to be kept in mind in differentials. This tumor particularly do not show any elevation of alpha fetoprotein, and the radiology is something similar to focal nodular hyperplasia. Presence of central scar will be there, and calcification is also shown as one of the findings in radiology. HPE, the typical eosinophilic tumor cells will be seen, and the IHC, which helps us to identify this fibrolamellar HCC, is CK7 and CD68 positivity. So as I said, it has a fusion gene of DNA JB1 and PRKCA fusion gene. It can be detected either by FISH or RT-PCR. So radiological and histological examination along with molecular characterization is very, very important for this diagnosis. So prognosis-wise, it is better than conventional HCC, and complete surgical resection is so far is the only cure for this tumor, and recurrence rate exceeds 50% within the first survival rate. So the case is presented here because of its rarity, one thing, and it occurs in young adults, and the molecular description for this patient. So these are the few case reports that we saw where fibrolamellar carcinoma has been presented in a younger age group. Thank you.
Yours also a rare. Again, adding to the list.
Yeah, but we have seen in DH. Sandhya, I'm sure you would have come across earlier cases of fibrolamellar.
We have seen cases.
Yeah, we have seen.
good prognostic.
Yeah, it's a better prognosis than the conventional hepatocellular carcinomas.
Punch
So,
madam has shown once.
yeah, we have seen.
Yes, ma'am, in young patients, it's a little scary because, it is to commit yourself as a tumor and patient is completely normal, otherwise asymptomatic, no
Right.
cirrhotic liver in the background.
Yeah, that's true. That's a very good
it's
point.
a little,
Yeah.
yes.
Yeah.
So we had a lot of discussion before we gave into the thing. So we just said atypical hepatocellular nodule. And then in the final resection, we could make out a very well circumscribed lesion with a lot of atypia and that
Very
particular.
innocuous, actually. You won't be able to pinpoint that, except for the prominent nucleoli. It would be difficult for diagnosis.
Yeah, and you don't see the lamellae in the biopsy. You only see these abundant eosinophilic. Only in the resection we saw that fibrolamellar area.
Very nice.
Some background.
I don't know why that everybody has not muted. That is the problem. Anyway, Valar, congratulations for an excellent audio-visual treat. It's an audio-visual treat, I should say, and you are going, what shall I say, from higher and higher in the knowledge and sharing knowledge. Really nice. And you should celebrate the 50th meeting in a very grand way. Because see, it is worth so much of knowledge is being shared in every meetings. So I think you should be really congratulated for your continued effort.
Thank you, ma'am. Compilation done, Valar.
Congratulations, Valar. Really.
Compile பண்ணிட்டேன் madam.
Compile பண்ணிட்டீங்களா? Very good, very good.
Ma'am, இன்னைக்கு எல்லாமே rare. Today being a rare disease day, இன்னைக்கு எல்லா presentationம் rare cases தான்.
Yeah, very nice.
Thank you.
Thank you, Dr. Valar. Thank you so much.
Thank you, ma'am. Thank you for all.
Thank you, Sita
to all
madam.
the presenters.
Thank you, madam.
Thank you, ma'am. Thank you, Sita madam. And ma'am, one more thing I want to say. Padmadi madam is super animating today. So
I know. Anyway,
congratulations.
She's not.
But she has left for a foreign tour, or she's still there. She could have joined.
She's all the
could have
more.
joined today in the meet. At least we could have had an opportunity to wish her a very happy and prosperous, peaceful, healthy, retired life.
Yeah.
Thank you, ma'am. Thank you, ma'am. Convey it to her, ma'am.
Please, Valar, do that.
You are the next HOD?
Yes,
you are the next HOD?
இல்ல மேடம் செல்வாம்பிகை மேடம் வராங்க MMC-ல இருந்து. Okay, ma'am. Thank you, ma'am. Thank you for all the presenters for the wonderful presentation. Thank you, ma'am. So we meet next time.
Next வந்துரு நீ 50th.
Yes, thank you.
50th போது வந்துருவியா?
50th நம்ம offline வச்சுக்கலாம் மேடம். Thank you, ma'am. Thank you.
Yes. Thank you.
Right. Thank you. அப்புறம் ஸ்லைட்ஸ் எல்லாம் ஒழுங்கா கொடுப்பா பிஜிக்கு.
Yes, ma'am. Definitely, ma'am.
பிஜி ஸ்லைட்ஸ்.
கண்டிப்பா மேடம், கண்டிப்பா.
ரெடிப்பா, வந்து வாங்கிக்க.
சரி மேடம்.
மண்டே வா.
சரி மேடம். Thank you, madam. Thank you.
Okay, bye.
So thank you all. Thank you.